Community to share our project, taking an ambulatory approach to reducing the impact of nausea and vomiting in pregnancy for women and their families at the Norfolk and Norwich University Hospital. 90% of pregnancies are affected by nausea and vomiting. The physical, psychological, and social impact can be huge for women and their families, the effect of which often reaches far beyond the index pregnancy. Abortion of wanted pregnancy and maternal suicide have been the result in severe cases. We collaborated with our local Maternity Neonatal Voices partnership to engage with service users and understand the current patient experience and identify areas where we could target improvement. We did this by co-producing a survey which was shared on social media and by running a series of service user focus groups. Our findings echoed national results. Despite safe and effective care being available, women experienced an average of 5 interactions with healthcare professionals before being offered treatment. They often feel they're not listened to and that their symptoms have not been validated.
Well, it was just, I couldn't do anything, so my quality of life just felt non-existent during those times.
And it was only really at that point when I was struggling to eat or drink or move, which was pretty extreme. You know, I think I waited till it was a very extreme level before I asked for help, that I was like, this cannot be something I'm expected to just put up with. And that's when I first spoke to the GP.
And I approached the doctors, as you do, and it was just like, oh yeah, this is just a normal.
It was hard, like with just doctors and stuff, to try and get the right help from early on. I did come up to hospital a lot for hospital admissions.
Because there's been a cycle of kind of patch you up, send you home, come back without anything effective.
And it was scary as well, because especially my first pregnancy, because you don't know what's normal and what's not.
Obviously there is a toll on the whole family. My daughter's had to get more used to me not being able to do things, which, you know, she's 2, so.
So at the moment he's got a little chart which is a countdown to baby sister arriving and mummy not being sick.
My third pregnancy this time round was probably my hardest overall, because I had 2 other children which I couldn't look after them.
Hyperemesis is really exhausting. So feeling like you're going to have to argue with somebody to get help for it is just like such an extra level.
We targeted a number of areas following the service user feedback. At the point of online booking, women are now offered advice about nausea and vomiting in pregnancy and signposted to sources of help. Community midwives were identified to be unequipped to advise. This was highlighted by service users and within a midwifery survey. We provided education and co-produced a dedicated midwifery resource to empower midwives to assess severity, provide holistic advice, and give information about medications. Women attending the emergency gynecology units are now offered written information explaining what to expect, offering advice, and explaining the next steps. There's a weekly virtual clinic to optimise current therapy for women who've had an admission to hospital or those on 2 or more antiemetics. Women are now able to receive care on discharge from the ward or direct from clinic via the virtual ward. They can attend the virtual ward hub or have IV treatment at home, which helps to provide a bridge between inpatient admission and establishing an oral antiemetic regime in their own home, going about activities of their daily life. This reduces the duration of admissions and prevents readmission. It means there's greater continuity and patient-centred, personalised, community-based care is supported. The midwifery resource and education has led to tens of appropriate early referrals already, with a positive impact on staff and patient satisfaction already evident. Patients have now accessed all aspects of our care pathway. We've demonstrated a more than 50% reduction in hospital bed days due to a reduction in length of stay and readmissions. This corresponds to an annual saving of more than £700,000. There is a corresponding reduction in carbon footprint equivalent to 23 trips from Land's End to John O'Groats by car.
Having the appointments with, or the calls with Sophie every week or twice a week helped, because we could just adjust things in sort of real time. It wasn't like I was waiting for things to get worse before we would adjust things. So that was loads better, because it meant it just felt like we were kind of maybe not one step ahead of it all the time, but keeping pace with it at least.
And it was just like everything was just, you need this is going to sort you. Do you know what I mean? Like, I was really looked after, and from then onwards, the rest of the pregnancy, I couldn't have asked for any better care.
And then I was with the virtual ward for a few weeks. I only went in for IV fluids once, but that was really good to know that they were there.
At home, like yesterday's treatment was literally, I done school run, they came in, literally I'd started, and I then started work straight away. After, I had half an hour gap afterwards and straight away started work, which meant worked really well.
It was just like such a relief to know that there are people who are listening, who understand, who I'm not going to have to argue with.
Once I've had my fluids and my anti-sickness in me, I then sort of kind of have a new lease of life the next day.
You know, there comes a point where you get beyond being able to help yourself, and I think never getting to that point has made it a lot better this time.
After having 3 pregnancies, all with a lot of medication, including the ondansetron, I've had 3 incredibly healthy babies, and you would just never know.
We're very proud of what we've achieved with this project, but feel there's much work to do still. And we believe one of the key strengths has been the specialist MDT nature of our maternity-led team. The project wouldn't have been possible without the support and enthusiasm and dedication of all our wider colleagues who we've engaged with throughout. Thank you.
Thank you. If it's possible to pause it on that screen now, don't worry.
Any questions from the judging panel?
Good.
Yeah, I've got one actually. Thank you for that. I mean, it sounds an absolutely fantastic service, and it's quite clear to see the impact on women has been significant. Obviously, it takes quite a lot to set up a service like this, particularly if you make it sustainable. So I was just curious to know, what were your initial investment costs to get something like this set up, if there was any? Or like education, training for staff, you know, what was the initial layout in order to get this up and running? Because it's quite substantial.
Yeah, we've been very mindful of that being sustainable throughout. We have been really lucky in that we have an existing very functional IV at home service and virtual ward that's enabled us to do that, enabled us to use it without any outlay of cost. But it was investment in education, which we as a team have taken on. Having Laura in post as a quality improvement midwife has been huge in terms of being able logistically to deliver this. And I think the value of that role has been really clear throughout this. I think it has taken a lot of additional time, and we've really owned this project in the setup. But at each stage, for example, the weekly clinic at the moment is very much run mostly by Sophie and partly by me, and some of those appointments are absorbed within our maternal medicine service, quite rightly so, I think. But the idea is that it will be acknowledged that there are no longer those patients on the ward being admitted, and actually there's scope within the gynae team or gynae SHO or the early pregnancy nursing team or midwife to be the person who has that touch point of call with the patient each week. And I think additionally, we see this service as changing over time. So we're really raising awareness and getting more referrals in at the moment. So we're almost seeing more patients than we were before, rightly, because they're all appropriate. But over time, we hope that the next steps of this project will be further resources and education for GPs. For the community midwife education will mean that women don't get to the point of needing our service in the hospital. And obviously all of this is a bit sort of long-sighted, I suppose, but we do think it will be an evolving picture.
Can I ask a question, Beth? Great presentation, and I think well worth doing, because most hospitals, women with hyperemesis just go from one place to the other. And I was trying to think about why I think that your project was such a success, because it's so difficult to manage this. And I think it somebody has taken ownership of this problem. Because often you'll find these patients, either they come under early pregnancy or they come under obstetrics, and really nobody knows where they should be, and therefore, so I think that's one part of the success. But you're a maternal medicine consultant. Do you have involvement from early pregnancy team as well?
Yeah, so we've engaged with the gynecology team and early pregnancy team throughout in terms of the guidelines that have been developed and the pathways, and particularly with the early pregnancy nurses. But it is one of those really difficult parts of maternity, isn't it? And not just in nausea and vomiting, but across lots of other aspects. And in maternal medicine, we know, I guess we take the approach that we are very happy to see people in early pregnancy before they've had their dating scan for other medical conditions, and this is part of that. And actually a lot of the problem is getting that sort of really early advice for women. And that was really strongly highlighted by the service users in terms of like just not having any idea, one, what was normal, and two, how to get any advice for it.
Good job.
Thank you.